our monthly coalition meeting. Today's October 2nd, 2024. Let's just get it rolling. I'm not gonna hold everybody here. We got basic agenda as our standing agenda. I got a few added items on here today, and our focus area today for the month of October. Supposed to be D4H and EM resource. We'll talk a little bit about D4H. We're not gonna go too far into it today, but Sean will be providing some information on EM resource today. All right. Let's go ahead and get through our roll call really quickly. We'll start with our hospitals, starting with Anderson Hospital. Hearing nothing, we'll move over to Alton Memorial.
Good morning, Phil. This is Aaron.
Good morning, Aaron. Over to Boyd. Nancy on by chance? Okay, how about Carlinville Area Hospital? And just in the nick of time, Eric for Anderson and Staunton. I see you just jumped on.
Yes, I'm here. Thank you. Sorry about that.
No problem. Not a problem. Fayette County Hospital. No Tina. That's strange. How about Gateway?
Morning, Phil. You got Sam.
Hello, Sam. How are you? Hopefully
Hi,
everything's
Sam.
well.
How are you?
Okay. All right. Down to our HSHS partners, starting with Holy Family. About St. E's.
Just like you, Phil, I'm still around. Brad Perry's here for St. E's.
Hey, Brad. Thanks. How about Breeze?
Stacy's here from Breeze.
Thank you, Stacy. It's funny because they put every time I say Breeze, they never spell it right. It's always Breez in the transcription. Let's move over. Who do we get? Oh, how about Highland? Hearing no one from Highland. How about Jersey Community Hospital? From Memorial Hospital, Belleville, and Shiloh, you got myself. You've got Sean. You got Scott Klosterman. And I know Lee's on the call, but he's no, we're not gonna lean on him too hard today. And you got Lee and Mike Gilbert. I'm pretty sure somewhere on here. Let's see who else. OSF St. Anthony's. How about Red Bud Regional?
This is Tara. I'm here.
Hey, Tara. Over to Sparta.
Dale is here.
So is Dan.
Dan and Dale. Thank you. Rescue Rangers.
Hey, you forgot me down at Chester.
Dang it! I know. I just skipped over all the memorial. My favorite memorial outside of. Don't tell Dr. Jernigan that or none of the folks here. But, and we got Dan and Dale. What about Touche?
Hi, Jade here for Touche.
Jade, awesome. Thank you. Over to our health department, starting with Bond County.
Wendy's here with Bond County.
Good morning, Wendy. How about Calhoun? Clinton County.
Good morning, Brett. How you doing this morning, Phil?
I'm doing all right, Brett. How you?
I'm good. Thank you.
Awesome. Anyone from Eastside Health District? How about Fayette County?
Kendra's here.
Morning, Kendra. Greene County? Jersey County?
Heidi is here.
Was that Heidi? Okay, thank you.
Yep.
Got it. I see Derek from Macoupin County. How about Madison County?
Oh, shoot. Here.
I see Deborah with Randolph County. Gotcha. Did we get anybody from Madison?
Hey, Phil, it's Michelle. Can you hear me?
Yep, I gotcha.
Okay,
Thank
perfect.
you.
Michelle and Jacob are here.
Oh, perfect. Thanks. We got Randolph and St. Clair County.
Vicky with Monroe as well.
Oh, awesome, Vicky. Thank you. Any more from St. Clair? Okay. Over to our community partners. We'll get down to our emergency response coordinator. Beth, are you on? Yeah.
Good morning, Phil. Beth is here.
Awesome. Any of our, well, BJC partners? You got me now, so I do have a new role. Any other of our BJC partners on? Right, hearing none. EMAs, any of our emergency management agencies on?
Good morning, Phil. This is Sam.
Good morning, Sam. How about our EMS brothers and sisters from MedStar?
Good morning, Phil. You got John.
Awesome, awesome. Thank you, John. And how about Abbott?
Hey, Phil, it's Leslie.
Good morning, Leslie. How about back across the river to SLU?
Phil, you got Brad here for SSM also.
Look at that, double dipping. Here we go.
Yep, something to it.
How about our Scott Air Force Base partners? I talked to Tim yesterday. I don't know if he's on today. No? How about our STARS and St. Louis Healthcare Coalition? Hearing none? Okay. All right. Well, I'm going to start under the open task due outs. Not that we have a whole bunch of open tasks or due outs, but I'm going to just take a moment to just talk about a few things that have just happened recently. Last night we did. Everybody got a call from the St. Louis, or what they call their HMACs now, their healthcare multi-agency coordination system over there. Regarding the potential fluids shortages from the Baxter plant and closing down in North Carolina, as well as the Eastern Seaboard longshoremen's strike, or whatever we want to call it. My brother-in-law is a longshoreman. My niece is a longshoreman. So this is one that's a little close to the family for me. But we had a conversation this morning as the Missouri Health, Department of Public Health, probably in concert with MHA, Missouri Hospital Association, basically is collecting data on healthcare agencies that have been impacted by the closure of the Baxter plant and potential supply chains disruptions caused by the issues with the longshoremen. So what they did is they provided Sean, correct me if I'm wrong, I'm trying to remember the name of the tool, but I guess it's a rapid assessment tool based on the given or the specific SKUs or line items, whether it's 500 mil saline or it's some dialysis support or whatever the supply is, for Missouri hospitals to fill out. So I'm just going to say from a BJC perspective, or we're filling that out from the system level and trying to get that information back to them today by 11 o'clock, because that was the deadline. So that's what's going on. So with that, I wanted to pause and just see if we had anyone who potentially started feeling the impacts or brunt of, or are in the preparing mode for a longer term outage. So I wanted to pause here and just see if anybody is feeling any impacts, or getting prepared to feel the impacts, and developing some alternative strategies to provide patient care. So I'm going to pause for a second. You guys let me know.
Hey, Phil, this is Aaron at Alton Memorial Hospital. Our supply chain manager briefed on this morning at our morning huddle. So they're taking proactive steps through BJC supply chain to address this.
Indeed. Okay.
Hey, Phil, it's Sam at Gateway.
I know they addressed us yesterday morning and our supply is also working with our pharmacy to try to get something figured out. It hasn't finished yet, but they're trying to prepare for it.
Are you guys a big Baxter user, or do you use any other?
Actually,
folks?
Baxter apparently is our only supplier
Wow,
of
okay.
fluid. So this may be a little cumbersome.
Okay, well, no, thank you for that, Sam. Okay. Any other hospitals or EMS folks that are on?
Hey Phil, this is Stacy at Breeze. I know the last 2 days, pharmacy has been talking, and so they're trying to get things worked out too. So we're just letting pharmacy take that.
Okay. Is there anything else afoot? I mean, I know HSH is another a fairly large system. So, has anyone from your supply chain side put anything out to the hospitals yet? Do you know? And I'll ask that between you and Brad and whoever else I got on from HSHS right now.
I haven't, not from the supply chain. Now maybe Brad or somebody or Patrick or somebody may have. It's just pharmacy is really meeting with the whole system. I know quite a bit today, so.
Okay. Any other? Okay, go ahead, John. You're about to talk for MedStar. Go ahead.
Hey, just so you know, we, again, we're small compared to, you know, big JC or SSM or HSHS.
Mm-hmm.
So, our central supply guy reached out Monday morning to ask them what kind of hold or, you know, will we be able to order our normal, we order probably, again, we're talking, we're small, 6 cases maybe every month or so.
Mm-hmm.
They told us that it would have to be everything would be being put on a priority on what was going to be needed to get it and where it would go. So with that being said, we also go after Braun, work with Braun. And so Bill reached out to Braun, and Braun, who's not really affected with the issues that are going on, but is already setting up to be able to help the big academies that will need it.
Mm-hmm.
So again, they told us that, you know, with our priority, we may be lower, much lower priority, but they would not cut us off completely. So I can tell you, I believe that they are looking at this not just as us or a region or a state of Missouri, but they are trying to look because they see that there is going to be a problem in the next 30 to 60 days.
Indeed, indeed. Thank you for that, John. Any of our critical like access hospitals experiencing anything like this, or you know, especially those that are not a part of a big system?
Phil, this is Tina.
Yes, Tina, please go ahead.
And well, I was trying to go into the Baxter did send our organization a letter on the 29th of September. Maybe everybody else received it too, I would assume. And they just had in there what they're doing with their inventory, their needs, and how alternate sources, fluid management, pharmacy, all the critical elements they have in place. And then I know an email came out today, but I haven't been able to look at that and actually review it to see what it had.
Okay. All right. So what I will say is just from a coalition perspective, RHCC perspective, what I would say is that you know, everyone, we don't have to go through this fully alone. You know, if we leverage or lean back on our just how we're postured here as far as a standing, your resource hospitals being there. You know, this is what being a resource hospital really means, is trying to look out. So when you are looking out for supply, if you're potentially going to have a supply chain disruption, and if your organization is really impacted by this, you want to start working with your resource hospitals now. You know, that doesn't always take the coalition to make that happen, I would just say that you stay kind of in tune with your resource hospitals. While we're not all directly, you do have some resource hospitals, associated resource hospitals that are within the same healthcare system. That's not always the case. But, by the way we're planned from the ESFA plan through IDPH and our own coalition plans, when we need those additional resources, whether it's on the EMS side that we're restocking or it's in another hospital, we may, just like with COVID, need to start looking at alternatives to what we would do day to day. So I would just encourage everyone to start some of those conversations now. My spidey senses aren't tingling too bad right now, so I think that's a good thing. But you never know how long this could go on and if something else were to be impacted at a later date and time. So again, just encourage you guys to continue to communicate. It looks like the St. Louis Healthcare Coalition is going to potentially, well, the next meeting that they're going to have, and it's going to be informational, it's going to be on Monday. So I'm sure Lee or Sean will be able to provide any additional context after that meeting to the coalition if there's anything of note. But as you guys see things arising, please feel free to reach out. And once we get the notion of if we need to set up some form of battle rhythm, whether it's bi-weekly, every other week, just to do a quick touch base, we'll do that. Obviously, we have our monthly meetings already on the calendar. So again, for me, I don't think we need to set up something that's weekly at this point. But that may change over the next week to 10 days. So we'll continue to monitor it. We ask you guys continue to monitor it, and we will try to work together. Sean, go ahead.
Yeah, great discussion, everybody. Appreciate that, Phil. And like he said, I don't know that our spidey sense is activated yet, but I just would like to share a couple just quick points that I learned back in 2014. I went through this when I was at the system level of BJC. And it for those of you that went through that one, it was pretty bad and things were starting to look scarce. Tina, I appreciate you mentioning pharmacy because they may have to alter some practices there. And just as a reminder, it's not just the supply chain, obviously. Phil, the tool you mentioned is the Rapid Impact Assessment tool, and it basically has about 75 line items that would be supply chain and or pharmacy combined. But also I would just mention, since this is what we do in the EM world is lean forward a little bit earlier than everybody else. Back when 14 happened, we did start monitoring and tracking our heavy OR cases. And so maybe it's not just IV fluid, it could be glycerin for irrigation, it could be saline, it could be sterile water. So some practices were changed in the OR, just FYI, if you want to start having those discussions at your facilities. And then for our resource hospitals, St. Louis is obviously reaching out to and including dialysis centers in their planning efforts. So I would keep them on your forefront, on your mind as you do any, community planning there with those resources with dialysis centers. Thanks, Phil.
No, thank you, Sean. I think all those notes that you're kind of pointing out as far as, coming up with altered standards of care, both in the OR or whether it's the ED or OR, or if it's in a dialysis center are really key. I mean, and again, we've hopefully, I know we haven't lost all of our COVID-19 chops, but we developed a whole bunch of workarounds then. So hopefully this again doesn't extend too far out, but we will continue to monitor and we're going to work closely on both sides of the river. And the same is occurring on the west side of Missouri as well, both Kansas City. And so both on the Kansas side and the Missouri side, they're working hand in hand as well. So just keep that at the forefront of your minds. If you need something or you feel something's getting a little shaky at your organization, don't delay. Reach out to your resource hospital or reach out to us. We'll see what we can do, and then we can again help facilitate communication coordination as we always do. Okay. All right. we're going to go ahead over. I don't think we have any specific IDPH updates. I know Beth, you'll get a chance to talk here, but I will cover a few things with regard to the budget. Okay, so the final budget has been oops, sorry, too many clicks there, has been complete. And for whatever reason on my screen, I know it doesn't look like that in the slideshow, at least of what I sent out, but on my screen, it's a little fuzzy on the side. But the final budget, we briefed this several times, was about $522,000, is the exact same amount that we've had the last 3 years. And it looks like it'll be roughly that going forward each year. And just as a side note, we receive as a coalition the second most in the state, as an individual coalition. Now, if you add up regions 7, 8, and 9, which is in the Chicagoland area, so the Chicago region, they actually have 4 independent regions there. They get about 2 million collectively between 7, 8, 9, and 10. Those EMS regions that are up there that make up the Chicago region. But as a standalone region, we get the second most across the entire state. I try to brief these numbers every year, especially when we go into a budget, just to maintain a form of transparency. It's part of our governance documents that we do this as well. So we want to make sure that everybody knows where we stand with regard to upcoming budgets and the like. So the deadline for the final budget for the EGRAM submission is 10/15/24. So about another week and a half, 2 weeks before that's finalized. So GMO is doing the final crossing T's, dotting the I's, all of those type of things right now. I will say this for those of you who do have a project proposal that you submitted and that was approved, and we'll talk about some of those here going forward. I just ask that when you are provided your paperwork or you're contacted by GMO, please have your financial folks or whoever you need to sign and everything ready and available. So the quicker we get that documentation back, the better. Okay, we want to be as far ahead of the power curve as possible. So please be very responsive when Quinn or Lisa reach out to each organization. Okay. We had to make some concessions in this grant. So, and I'm going to talk about some of those concessions where we had to lower some funds to make room for our final kind of large purchase item, which is our alternate care site sheltering system, the DLX, which we actually have been put into use. We only got the 1 tent last year. What we're receiving now is the remaining HVAC units, 4 new HVAC units, 3 more tents that go around what they consider like the hub, what they call the hub. So just picture, we've shown pictures before, but just picture like a center hexagon and then 4 tents springing out from that center to make a alternate care site. We've been using it with some good success. It's a little smaller than some of the shelter systems that our regional medical emergency response team has been using in the past from St. Clair Special Emergency Services. We have California tents really large, but it takes a really long time to put up. This one probably takes 2 to 3 folks, 20 minutes, 25 minutes or so. So that's good. So it helps us with more rapid deployment and a few other more flexibility things. So that's why we're going to it. And it's the last big purchase that we've had. And we would not have to do this. We'd be free in the clear in this new budget period had we not had to replace the Philips telemetry set that was being sunset. So we're ahead of the power curve there. And once this is done, we'll have a little more flexibility going forward. As a point of note, just so everybody knows, Memorial as a fiduciary is authorized upward to, I won't say a limit, but upwards $250,000 of whatever the budget is. So that's almost 50%, 47.8% to manage the grant in and of itself. So to do all the things we need to do, it helps pay for salaries. As I've discussed in the past, part of my salary was paid by this, part of Lee's, part of Sean's, and Scott's salaries are paid with this. Okay, so we only use in the end, as you can kind of see there, right around 90. At least we budget for about 90,000 for salaries, and that's a slight increase over what we budgeted in the FY24. But that's because we had some transitions and job titles, a whole bunch of other things. And with that, we currently use about 37% of the total overall budget, roughly 190,000, and that's dedicated primarily to salaries and the leased new warehouse space. Before we got the warehouse space, and utilities, which takes about 45,000 of that, we just used our current warehouse space that we had. It was very inefficient, but we used it. But now that we have a dedicated space, that's moved up. So we were probably using anywhere between 120 to 150,000 or 140,000 a year of that. So because we've tried to, at least my goal has been to make sure we still have room for project proposals each year. And if we did it on average on the last 7 years, we've averaged around $108,000 per year in project proposals across hospitals, health departments. Our EMS folks still haven't taken advantage of it as much as I yell about it, but nonetheless, we try to not give away a lot of money, but it's your money, it's your federal money, but we try to get it out into the right spots. Some notable reductions in the budget. Okay, we cut down some of remerch supplies, about 1,500. We will not renew our Shield Us subscription in the upcoming year. We may be able to pick it back up afterwards, but just because of a lack of use across the region, we've had it. This will be the 3rd year that we have it, and it will expire in, I think, February of this year. Then our Coalition Office 365 account, we're going to sunset that. And it says 1,200, but that's just how much we're cutting off of this year because it crosses budget periods. So the total amount of that between the Office 365, Teams, and a few other things is around $3,700 total. So in the outgoing years, it will be completely, we'll gain about $3,700 back to the budget. But yeah, that will sunset in April. We'll just use our Office 365 that we have here with BJC. So that means there will be no more Coalition accounts. I don't know if you have or have been using your Coalition account, but that swillhope.org Coalition account will no longer exist. So it's normally first initial, last name. But after April, it will no longer exist. So I would ask that if you were storing anything in the cloud, because everybody get like 1 terabyte of storage, and a few other things, we put that in place primarily as a redundant form of communications should we have an instance. I'll just say like a CrowdStrike instance, even though that was Microsoft, but we have an instance where an organization is unable to access some of their cloud documents for whatever reason, that they would at least have that as an option. Years and years ago, we provided folks with Microsoft tablets, a few of those things, very hard to manage. So we didn't bring those back, and they're probably gone by the wayside just by age. All that said, that Microsoft account will go away. Okay. Trailer maintenance, we had to lower about $1,000, and we put a lot into trailer maintenance every year. So some of that's going to have to probably come out of Memorial, BJC. Our Starcom 21 bill, we readjusted and cut some accounts that were not used. It lowered it about $1,400. And our AT&T FirstNet phones, we lowered about $3,500 based on usage. So I know Lee has worked with a lot of folks and gained some of our FirstNet phones back, and we're going to look at it in a slightly different format going forward on how to deploy those if and when needed. We'll use them more of a deployable asset. But if you are in need of something like that for your organization, please let us know. We don't want you to really be without, but it did save us about $3,500. Over to this side. So final project proposal amounts. This is what we have that's in the budget. I know Monroe and Bond County, their project proposals were just shy of 25,000 and maybe just north of 25,000. We had to reduce them down 5,000 to make room. So yours will be apportioned appropriately. All other project proposals were not impacted. And so that's about a $10,000 drop across project proposals this year. I see Aaron said, and I asked for other folks, I'm looking in the chat. He says slides are on Teams are not advancing. Are your slides? Can someone else give me a thumbs up or heads up if those are moving or not moving? If maybe I need to reload the slides.
Yeah, mine's showing the roll call.
Mine are working.
So yours showing roll call, Aaron, but John says his is working. Anyone else? Can you guys see the final project proposal? I'm getting nothing but thumbs up, Aaron. Maybe you might want to drop off, jump back on.
No, I'm just using the ones you sent out. So
okay, so you got a copy of them with you. Yeah. One of the reasons I send them out, just in case stuff like this happens. Okay. So, but again, so we're about 10,000 less overall. And like I said, we're normally just north of 100K a year for project proposals. Some major milestones for this year. And the outgoing years will start with just the transition from the traditional HVA to the RIS 2.0. Sean's going to talk about this here in a second, but we will be transitioning. So some things we got to get done before the end of the year. So I'll let him talk to that. Just I'll sweep through the rest of these here in a second. The Mercy, as we kind of talked before, we are partnering with the St. Louis Healthcare Coalition to make sure that we work together on this one. We had the first meeting, I think, was it last week, I believe? Maybe a week before last time. It's kind of moving kind of quick. But that one, mission goal there, based on the documentation that ASPR's provided, is 10% of the licensed beds. So for us, we have around 2,000 licensed beds across the entire region. So for that, it's roughly only 200 patients. If we were to look across the west side of the river in the St. Louis area, I think that number would probably boost up to around 400 plus our 200, giving us maybe around 600. We'll come up with the final numbers at some point in time pretty soon. But I think it's very doable, the number they give us. So we'll probably have to introduce a few other things for folks to think about during the Mercy. But put that on your plates now, because when we ask for, and that will be soon, for our participants, we want to make sure that you're set aside to fully participate. I want everybody to keep in mind, we talked about this back in June or July, that our goal is to have, we have to have an extended downtime full-scale exercise. And we may partner, we'll probably partner again with the St. Louis Healthcare Coalition, but that will probably be an extended exercise. And, when I say extended, I'm talking, 48 to 72 hours of an exercise to really, really achieve the objectives that we'll probably need to for an extended downtime. So keep that in your mind over this next budget period. And we're targeting I think it's going to be FY27 for that. The readiness assessment tool, this is going to require executive committee input and review. We no longer have the coalition assessment tool, but they've got some new tools that they've unleashed. Those new tools were unleashed, and I think both Lee and Sean participated in them, the education for those last week. Sean said he felt like, drinking out of a fire hose. So probably drinking out of a fire hydrant more so, because it was probably a lot to go along with it. They're putting a lot of work and effort into making sure we understand them fully, but it will require all of the tools that they've shown. It wasn't just the rating assessment tool. They actually have the integrated preparedness plan as a tool. They have a whole bunch of things as tools that are supposed to, I'm using air quotes, help you do your job. We'll see how much help they are in the end. Some plan and annex realignment. Some of this is going to be a little bit of a Herculean effort. Some of it will be fairly mundane, but we've talked about this before. But I just want to be clear on it. We're going to extract portions of our current plans that we have today to make independent plans. For instance, the resource management section of the region's EOP, we're going to put that in its own separate document. Lee's already started chopping on that, and we're going to put that on its own separate document. We're probably going to have a few workshops or just to go over it and get everyone's input. But the goal is to really, really make sure folks know where stuff is, how they can understand the availability of those assets. And I'll just say the decon trailer is one of the assets. The oxygen trailer is one of those assets. Whatever those things are, how to go about requesting them, etc., into its own annex. We have all of that basically now in our EOP, but they're asking for a standalone annex for this. The continuity of operations plan / annex, we will extract the orders of succession stuff that we have out of the EOP now and kind of beef it up. I don't see that being more than maybe 3 to 4 pages, 5 total if you're counting the cover page. So not a big lift there. The independent surge annex, this one. You see, I got a green. New mission goal, surging to 150% of the average daily census of your region. So let's go back to the Mercy. So I'm going to grab the laser pointer. Laser pointer, we're going to practice the mission goal of 10% of licensed beds. Okay. Now they want us to create a surge annex that can go to 150% of the average daily census. So for us, we ran those basic numbers. I used some information that IHA gave us years ago, but I think it's still valid. For us, that means that we would have to kind of surge somewhere on the order of, what do we say? Oops, I'm sorry. I think around, for us, roughly 600 patients. So if our average daily census or was 450, it was either 450 or 600. So I can't remember if the average daily census was 900 or 1200. I'm just escaping me right now. But that's either going to be 450 or 600 patients within the confines of the Edwardsville region. Anybody see any problem with that? I don't know. Maybe it's just me. But and then a new patient evacuation and movement kind of annex. And we're looking at that not from the hospital or healthcare organization lens. That is, you understand that you have to have an evacuation plan. All you folks, TJC, HVAP, all those folks come through and check for that, just for CMS requirements. We want to make sure that we have a plan that is fully vetted, that truly discusses how we're going to manage an emergent and non-emergent evacuation of a healthcare facility. Good thing is we had a little bit of practice when St. E switched, at least for the orderly non-emergent evacuation, when they moved from downtown Belleville out to O'Fallon. I think that's a good starting point for that. And then we can work on the emergent evacuation. But we're going to work to get those. So lots of workshops and seminars on the horizon to help get some of these things done. With that, I'm going to pause. I'll let Sean kind of talk a little bit about the HVA and RISC 2.0. Sean?
Thanks, Phil. I'm going to bring Lee in here whenever Lee's ready to jump in as well. He's on the road today, so I'm going to sub in a little bit on the discussion on the RISC 2.0 on the toolkit. I'm aware that last year this was discussed, the potential use of the RISC 2.0 toolkit for the HVA for 2025. And understanding that, it is a lift. BJC began utilizing that tool last year. So I'll let Lee speak to our kind of discussion about seminars and workshops. But as far as this year's HVA, I'm still aggregating that data. I believe we got 10 HVAs that actually were sent back to us. So we will have those out in the coming weeks in preparation for next month's meeting. But I think at the same time that Lee and I are kind of focusing on this Risk 2.0 seminar / workshops. I think that'd be a good time to have discussion about how we'll utilize the current HVA responses in preparation for planning efforts next year. And then we'll figure out how we're going to transition to that Risk 2.0. But as you know, the region, we're responsible. It's an annual requirement in HPP, the RHEC grant, part of our scope of work to complete that. So we will share that in the next couple of weeks, and then we'll figure out how to transition to 2.0. And I'll defer to Lee if he wants to take it away from here.
Hey, good morning, everyone. It's Lee. I apologize if you hear heavy breathing in the background. That is my ever-present canine companion in the back seat who's tired of being there. But on the Risk 2.0 side, we have the mandate, and Phil hold me to this to make sure I'm accurate, but it's got to be done by the end of the year. They want us to complete that and as a region, which basically means each of the facilities would create a profile or an account in Risk 2.0. You'll complete your HVA in the Risk 2.0. It does provide you some good analytical information for your usage for your facility, obviously. I mean, that's what it's intended for. But it allows us to roll all of that information up into one HVA at a more of a regional level that holds more true in their mind to what it is they're looking for. And for anyone that has played with Risk, there are some areas where you're going to look at it and go, that's just not right. We are very much aware, and we've brought that to their attention, because there are some things where the math makes you wonder how it mathed. But overall, it is a mandate that we have to do that. So we will set up some dates. I should be back in the office tomorrow, so Sean and I will sit down and come up with some dates to do basically like a seminar for you, if there's nothing else, to walk through the Risk 2.0 process. There are some other videos that are available online that will familiarize you with the process. It's not necessarily tremendously challenging, it's just cumbersome. But I think in the long run, it'll be a good thing for us once they finally get it finalized the right way. Am I missing anything, Phil, Sean?
No, I don't think so, Lee. Oh, go ahead, Phil.
I was gonna say, no, you didn't miss anything. I would just like to elaborate on one piece that I have here. Where when I put the words here, it's major undertaking. We'll provide we'll provide initial education support to complete. But when I can recall going through this, Lee and I sitting around here at my desk, they're going to ask some questions that, you know, if you're just the HPP guy or girl at your hospital, you may look left and right and go, I have no idea. They'll say, like, how much is this going to cost your organization over the duration of the outage, for instance? And it'll say 0 to 25,000, 25,000 to 100,000. And you're like, what? I have no idea. So you want to have some consensus here with some of those estimates, because the way it calculates, the way it takes in its calculations and how they're weighted sometimes is based on the financial burden on the institution as well. So it's not simply, you know, a traditional risk probability index where it's occurrence times catastrophe based on your level of preparedness. It includes that too, but it includes some other things. We do have, and we thankfully, one of our other up in Region 8, they provided, or they worked with the folks at ASPR or the Risk 2.0 folks and got extractions of the actual questions within the Risk 2.0 tool. So all printed out, you know, on Word documents. One of those documents was 150 pages long, I believe, 150 pages long. Now, some of that has to do with just the spacing and a few other things, but it was fairly long. And the other documents were fairly short, like 8 pages, but one of them was fairly long. I'm going to provide those when we send the meeting minutes out, just so everyone has them. So even if folks that won't be a part of this can take a look at it. The other good thing about it is that if you've already started a version of this, we did it about 6 months ago. in our conversion with on the BJC side. The BJC folks at the time were like, all right, we're looking to redo our HVA, and during our emergency management steering committees, we looked at this, and the flaw that it had at the time was if you were to create, you can create what's called basically like a parent account or an umbrella organization, which we did as a healthcare system with BJC. But once you did that and you became a part of that system, that information wasn't shared to anyone else. Now they have it's worked out to where you can send an invitation to any other healthcare organization that has an instance done. They will show up and they will accept that. So I'll use HSHS for example. If HSHS decides to do this, they can still be a part of the Hope Coalition's instance of risk, and we won't have the ability to manipulate any of the data there, but we can review the data and it will roll up again into our own instance of risk 2.0, if that makes sense. So it's very secure in that regard. It doesn't you won't see any financial information. There's no patient information or any of that type of stuff in there. But all right, so I think that's everything. Eric, I see you had your hand up.
Yes, sir. Thank you. Where's this requirement coming from so I can plan my life moving forward? Who is the authorizing body to make this a requirement?
It is when we say authorizing body, it is it's in the scope of work from IDPH, and above that, it is in the notice of funding opportunity for from ASPR. So with regard to if we have the grant, if we're going to participate in the grant, this is one of our participating conditions. I think the metric that we put in our scope of work is to get at least 85%, I think. So that's, I think, 15 out of 19 of the hospitals in there. I would love to have everyone's in there because in the end, I do think it's a good tool, but it is a little cumbersome to do it the first time. It is a little cumbersome, but it does stay there, and you can create iterations of them, so you can have you can start from where you left off. Kind of similar for those who recall us using SIMP back in the day. So hopefully that answers your question.
Yeah, I think it does, Phil. I don't think most of us who do emergency preparedness. I mean, we're used to pain and a little bit of level of cumbersome as long as we see product from it, right?
Yeah.
So the actual standard specifically says risk 2.0.
Yes. Yeah. It does say 2.0. Yep. They called it out specifically. In the past, it just was generic, right?
Right.
But you will kill once you transition. I can say that you will kill two birds with one stone, because you can say when Joint Commission does come in, we've moved over from, let's say, the Kaiser Permanente tool, which you may be doing routinely, or if you were still using SIMP, and then you can kind of give your region spiel to it too. And that shows that we're participating with our region because blah, blah, blah. So you can kind of kill a few birds with one stone with it. So I'm trying to look at it half full. I will tell you the 2 hours that Lee and I sat here, because we did it for two hospitals. So we had to do it for Shiloh and for here at Belleville. That it was painful at first because we did not know what to expect. If we were to have at least had the printed out questions like I'm going to provide everyone here, it would have made it a little easier because they were it was like it was shooting from the hip. It's like, oh, okay, we'll figure that out. So.
You've been doing this a while. Do you suspect that this will be a tool that will be recommended by the overseeing people like
in the
Joint
end
Commission and such? Yeah.
In the end, I do see it. Yeah, I see them as like the original Risk 1.0 was horrible. So if you ever had the opportunity or the pleasure of having to use the Risk 1.0 tool, it was bad. This isn't bad. It just will take some time, the first one. And that's why, since we've gone through it, and I'm going to solicit I'm going to solicit some assistance from our good folks over at Big Barns, TJ, who helped lead us through it, who helped build the initial instance and did some initial education. I'm going to enlist his assistance as well. We want to make sure that for those who are going to go through this the very first time, because again, it's not the easiest the very first time. But we want to be able to walk through and we want to, do some over the shoulder. So we're going to have some hybrid events so you can come over here and sit in our office along with us and we'll have somebody sit right beside you as well. So, and we'll have it online as well. So we're going to try to attack this from multiple angles. But if we can we've already got 3 because we already got Alton, we've got Shiloh, we've got Belleville. So all we got to get is 12 more to meet our 85%. I think we can get everyone. But I do understand the challenges with that type of change. Beth, I see you had your hand up. Sorry.
Hello. A question about this system. You say that it will all roll up into a regional assessment, a regional document. I'm assuming that means just on the Illinois side. Is there
Nope.
capability? Oh, it's for both
You
sides, the entire.
Yeah, you could be so like if you have a healthcare system, I'll use BJC. I'll use BJC because we can put all the St. Luke's stuff that we have out in Kansas City now into it. If you have an instance and I just have to search your name and I find you, it'll send whoever that is. It could be Carl, it could be whatever OSF up in Peoria, it could be anywhere and it'll roll up just as long as you accept the invitation. Yep.
So we could include the facilities that are within the St. Louis MSA.
Yep. We could.
Okay, very good.
We could.
All right. Thank you.
Mm-hmm. Any other questions? I know that was a lot, but in Georgia, I do have your email. I'll give you a call. The last section, and this is for this entire budget period. I'm not going to say it's not just for FY25, but there is a refocus on health equity. Okay. And we're going to try to put on some seminars, workshops, and everything, and you can kind of see, I always like those pictograms here showing the difference between equality versus equity. So we want to make sure that we are helping create resilient communities, okay, by identifying those health disparities and outlining actionable goals that we can kind of be involved in as a coalition to both our rural and urban communities that are underserved. So, and I know that especially a lot of the big organizations, the HSHS, the BJCs, the OSFs, I know that they have these health equity metrics that they're tracking. I see them, but that's only one piece of it. We got our EMS partners, our health departments. We've had projects over time that have lent themselves to health equity because in some of our rural areas, in getting to large Spanish-speaking populations for the migrant workers that are here. And otherwise for reaching out and trying to expand local clinics. We've been seeing great efforts there, and we've had project requests that have supported those directly. So those are good things, and we want to continue those going forward, but we want to try to do it a little more deliberately. So I think this year, I'm going to say springtime, we'll start to put on some seminars, get some guest speakers, some workshops, or things that we can do at the organization level, whether that's for an EMS department, private or public service, or healthcare facility. You pick the facility type. Anyway, but again, this will not just be an FY25. This would be something that we need to kind of really bake in, and you'll see some of these markers in the strategic plan. As long as you get it done before December 31st, 2024. Hopefully, fingers crossed. All right, back to regularly scheduled programming. Beth, what do you got? from a health department perspective?
All right, I'm gonna go quick because I have another meeting in 5 minutes. I'm on the wrong page here. I'll give you the short version. H5 influenza A, there was a positive in Missouri. I think most everybody has seen that now. No known contact with dairy cows. So CDC is all over this. The person has recovered. There was some contact with healthcare workers. So the CDC has collected the blood of those healthcare workers and has sent it off to their lab for work. But apparently there's trouble with transportation because of the hurricane. So not sure when we'll get those results. I'll skip over the diseases. In the region, we have 2 new emergency response coordinators for local health departments. East Side, and I believe he is on the call, and St. Clair. At IDPH, we have a new FEP coordinator. Her name is Kay. She's from Missouri, and we're happy to have her. As for changes in the SNS or MCM program, Dr. Carla Little has left IDPH, and so we will be finding a new person. And IDPH has moved our RSS or our warehouse. There'll be some changes coming in with that as well. FEP and Sierra grants have been approved. Working on signatures for execution. I'm not sure if any of them have been executed yet. If not, they will be soon. Questions?
I did receive a question, and because I haven't got a response back, but maybe I could have asked Linda. But has there been any movement on Greg's position?
Not that I've heard.
Okay. Any questions for Beth? Okay, hearing none. I'll open up. I think Rachel jumped on, I believe.
Yeah, I'm here. Can you hear me okay? Trying out new headphones today.
Yep. Look, you sound like a radio personality. Go ahead.
Awesome. Okay, cool. Well, thanks for giving me some time for updates quick. I apologize. I was a few minutes late, so I think I missed the bulk of the IV shortage, but in quick summary and apologies for repetition, we stood up our HMAX on the Missouri side of the river this morning just for monitoring. We did level 2. We will be continuing that. Phil mentioned and Sean mentioned that we're going to have a meeting on Monday just for continuing updates and stuff. Missouri is also doing standing up our MICT, which is the statewide coordination, because we're going to coordinate across healthcare coalitions through the state. So that's going to be our goal for standing that up as well. I know you mentioned your spidey senses. Ours probably aren't, in critical mode yet, but I think we're using this as some good practice and some good careful monitoring for a situation that could get bad if we remember some past experiences. Yeah, other than that, for that particular situation, I'd be happy to answer any questions or continue sharing any updates from the Missouri side. We do always invite our Hope Coalition coordinators to those calls. So you guys have the awareness that we have since, we work so closely and we know that things don't stop at the border. Otherwise, for HCC STARS updates, I really enjoyed your guys' conversation around the RISC-C tool, the 2.0. We just had a very similar conversation with our partners and decided to use that for our HVA on this side of the river as well. Excites me that you guys want to use it for purposes of collaboration. And then what Beth brought up about possibly using it across state lines as well. Then when we have the same data, it'll be easier to collate. So I'm excited about that. We are also working on all of those other things that Phil had on his lovely slide back there, the readiness assessment, the MRSE, all that good stuff. As for STARS updates, we are approaching the UASI grant for our St. Clair, Monroe, and Madison County partners. The UASI grant opened period will be coming up. I think it opened yesterday. I could be slightly off about that. My apologies. I'm not looking at a screen right now for that, but we are going to be seeking out proposals for the UASI subgroups from all of our subcommittees for FY25, and those will be due in December. So we'll talk about that more at individual subcommittee members, but just kind of keeping all you guys updated as to where we are with that process. We also, and very exciting, non-boring news, got 2 new staff members. One of them is on the call. You guys will be familiar with both of them. We may have slightly poached 2 of your St. Clair County employees and brought them over to STARS to join us in our ranks. Kara Rosenkrantz and Bridget Frango will be joining us. Kara's on the call today. She'll be working on a whole bunch of HPP stuff with me and HCC stuff, and then Bridget will be handling some of our other subcommittees, as well as just being general asset to the team. So just wanted to let you guys know that we are now fully staffed and ready to roll. So as Sam said in a meeting this week, you can bring on your problems. We have the people to handle them. But otherwise, I think that are all of my updates. Any questions about HCC STARS stuff?
Awesome. Thank you, Rachel. And as she said, as we work on a lot of the exact same things. And some of these, I feel sometimes we feel like they're rushed. But I want everyone to kind of understand one thing about why some things feel delayed a lot of times. We always are on 2 different schedules, the federal government schedule and the state government schedules. Most of the states are 1 July to 30 June, and the feds are always 1 October, 30 September on their fiscal calendar. So when they produce these products, like the readiness assessment tools or whatever, and then they provide this training, they provide it like the right before the week of the first of the year, because the first of their fiscal year, which ends in September. So we're always kind of 1 quarter behind. I've complained. I will complain again this year at the National Healthcare Preparedness Coalition Conference to whomever at the CDC and or ASPR will listen, that they need to move everything to the left, or all the states need to move everything to the right, so we can work on the exact same timeline. So please have some grace when sometimes we say, hey, we need you here for this because we're trying to meet a timeline or a deadline. We want to try to do that, but it's kind of hard when we don't have the final scope of work until late for us. So we may have an inkling, but sometimes those inklings, we'll work on them and then they'll change. And then we've worked on something for no reason. So thanks, Rachel, for situational awareness and everything there. Mike, if you're on, I can talk if you're not on for Remert. Okay. No, Mike, I will say this. Shouts out to Remert and SES and for a lot of our volunteers. This past weekend, we did work Belleville Marathon. Great turnout. I think we ended up with 585 actual runners. Some folks did have to, based on the weather, they probably didn't show up that day. But it was a very good event. Everybody was expecting rain at some point, and it never did. It stayed clear with an overcast, but it was no fog, no. Temperatures didn't get above 72, 73 until later in the afternoon. So great effort from everyone there. I think we only saw 3 patients. One was a wasp or a bee sting. The other was a gentleman with like a hip. We had some gentlemen come by in search of God during that time frame. So it was a light day. light day. My back doesn't feel like it was a light day still because of we had to pack up everything. And also, Remer's working on a ton of things coming up outside of whether it's races or other major events that are going on, but continues to be a workhorse in this community. One of the reasons why we make sure that we fund them with supplies and training opportunities when we can, because they do a tremendous amount, and it's an all volunteer force. So thank you, team. Upcoming events we got here. Weather and Storm Conference down in Spark is week after next. So they always put on a great event. If you guys have not participated down there, I think they do a really good job. Ever since I've been doing this job, when Mike Maddox was running things down in Spark, they've done a great job with this event. So we would hope that you guys can participate. With that, we got some decon courses coming up. I think those are all full. I don't know if there's even any room left. The St. Louis Integrated Warning Team meeting is on 24th of October over at Gateway Convention Center, Collinsville. The Responders in Human Trafficking course, 25th. We've sent stuff out on this before. We sent out some stuff on the IHA Cyber Disruption webinar. It is the same day as our next region meeting. So we are going to change the time. We are encouraging everyone to participate if they can in this webinar, because this is one of the things we're going to put on some webinars and host some things in the future, but this is a good primer. I know for a lot of folks, or some folks actually did not participate in CrowdStrike. Lucky you. But again, our extended downtime exercise is going to be a cyber related event. So this is a great spot to start getting some of that familiarization. We will discuss Risk 2.0 on that day as well. So that will be a little more in depth. So we'll do a speed run through our standing agenda and knock down some Risk 2.0 and potentially National Weather Service information after that. STL HCC Summit, November 7th. All right, this will be the second annual. Do I need to put that here? Second annual? I think second annual HCC Summit. So that's going on. Project proposals due November 15th for the next fiscal year. And then the Mercy exercise, just keeping it at the forefront of your brain. Will be going on in the spring. We'll have a date TBD, but it needs to be early enough so we can get everything done and back to the state, at least on the Illinois side, by April 30th. That's the requirement for us. Before we continue, I know we're going long on this meeting because we do have some EM resource announcements just to make after this, and that won't take that long, but I wanted to open up the floor, make sure folks had an opportunity to bring up anything that they had in their minds or things that they need the coalition to be aware of. So I'll pause for a second.
Hey, Phil, I'm going to jump. Oh, go ahead, Lee.
2 points. First point, wasn't there a November 18th something regarding the grant that we were hoping to get some participation with? I don't have anything in front of me except a steering wheel at the moment.
It's the Asper led. I'm going to go back to it. I think we have it on the slide. Let's see really quickly. No, I don't have it on the slide. It is, I don't know if it requires other folks other than us, but I do have it here. Give me one quick second. But while I do that, Sean, you can go ahead. I will make the announcement of what that is here in a second.
One more question, one more point for the group. We're already getting requests for decon classes for the spring. If your facility wants to host a course, please shoot an email over to Sean and I so that we can try to get those dates coordinated in advance and kind of get a roster built for the year.
Got it. And I'm just pulling up the work plan here. Give me 1 second. 11/18. It is the participated. Okay, it's participate in the Asper sponsored risk assessment workshop. So that's where we do want. So we will. It's not for the entire coalition. When it comes out, we will provide the link to wherever, when and where that's occurring. But we will be asking folks on the executive council to participate in that, because this will help finalize that risk assessment, because that risk assessment is due 31 December. So that's 11/18/2024. It's the ASPR-led risk assessment workshop. Sean, you had something?
Yeah, I just wanted to add to that October 24th integrated warning team meeting. That's actually the National Weather Service. And I'm pretty confident that most of the people from UASI region have been involved in some of those calls with Kevin Deitz from the National Weather Service. So they've got a pretty packed agenda there. It's a 6-hour meeting. I think it goes from 8:30 to 3:30, and we'll push that out with the other information that Phil's going to provide. I'll send the email. Please make note when you open the email to register for that conference. It's there's a link to register. However, at BJC it won't open. So our cybersecurity folks have that blocked for some reason. In the email, Kevin says, please just respond to him if for some reason you cannot open that link to register. And that's, again, it's going to cover multiple topics from flooding, flash flooding. They'll talk about incident support teams in the region that help during a flooding response, as well as they'll get into, Phil mentioned some of those vulnerable populations and underserved populations. How do we get those warnings out to them? So great collaboration with the National Weather Service and Kevin and his team. So we'll get that email forwarded out to you as well.
All right. Thank you, Sean. Anyone else across the region? Any announcements? Okay, hearing none, I would ask that we're gonna go ahead and we'll end the formal part of the meeting here, but this as a part of our focus month in our calendar today, we just had a few notes and reminders regarding EM Resource. So if you don't need to, or if you don't use EM Resource, or you don't want to know about EM Resource, feel free to log off now. This will be loaded up to the YouTube page later this afternoon. But for those, if you're hospitals, EMS folks, or what have you want to stay on, please do. But we want to make a couple announcements. Sean's going to just lead us through this really quickly. So I'll pause here and you just tell me when to move the slide, Sean. Thanks.
Thanks, Phil. Yeah, so this is basically a review of what you covered last year at the same time. Unfortunately, we are still struggling with our day-to-day MCI query responses. I'm sorry, not day-to-day, our event or exercise type MCI queries that we push out once a month, once every couple of weeks if there's a real event. So kudos to everybody on the daily bed tracking. That's the response rates are awesome. Very impressed. And Phil's got up this first slide here. So as part of our regional EOP, we do require a minimum amount of staff to receive the notifications. And I can tell you, just coming from BJC and their 14 hospitals, what I've experienced is when there is low response rates, typically there's been some turnover at that facility and the appropriate people have not been entered in to receive the notifications. And Phil's got the slide up here. This is actually in our regional EOP. And it's section 10.5. So those are, most hospitals either have a bed czar or their ERs are answering the MCI queries. I know a lot of times the house soups will answer the daily bed queries because they have all of the ICU and the OR numbers, etc. So what we're asking is just for everybody to kind of go back and take a deep dive into the preferences that are set up here, and you can go ahead and advance, Phil. And so we've got some slides here for you to follow. Yeah, that's perfect right there. This is what tends to, I guess, get missed or changed, or people aren't aware that the level of notifications that are in here that you can choose, and then you can choose how you want to receive them. Like, I don't want to be called for, maybe a bolo at 3 a.m. while I'm sleeping. So you could go in here and set the times, and you can set the parameters on the notification methodologies when you're receiving these. So I think this is where, if you need help, there's obviously these slides can help you. And then Phil, I'm going to take over just for a moment. If can I take over there? Or do you have EM Resource up?
I don't, but if you want to you can share your screen. it should be able to pull your up. You should be able to share without having me to drop
Yeah,
it.
it's not letting me share for some reason.
Okay, well, give me one quick second. One quick second.
Yeah, so basically what we've noticed, and I'll just go through some numbers here. So I ran a report from our exercise that we did on July 16th. So as part of our HPP grant, you know, Lee and I do some STARCOM radio drills. We do these EM resource drills. We do the D4H drill, which he did the last week or two. And our response rate was 59% for the coalition on that one MCI exercise. So now the good news is Mr. Brandemeyer had some active shooter exercises, and we pushed some out during those, and that response rate was up to 65%. And then we had a Metrolink accident, and the response to that MCI was 76%. So getting a little better. Again, kudos to everybody for your daily bed, because that's really important. But we need to figure out how to fix this gap with the MCI query responses. And Phil's still trying to figure out. I was going to show some, for those of you that may not be as familiar with EM Resource, how to find documents that can walk you through this. So that's what we're paused here for a moment. Any questions while we're waiting on Phil? What I will tell you, when I looked at these response rates and I ran the reports, there's 5 or 6 hospitals. So I think it'd be a good opportunity for me to meet a few of you. So I'll be reaching out individually to those 5 or 6 to see if we can support in any way. And I know there's obviously turnover does occur, and finding people to take ownership of this and enter the appropriate, whether it's a title or person, can be challenging at times. So we'll just need to make sure that we're putting in the bed data so that we can respond real world. I will tell you, looking at the numbers look obviously appropriate, whoever's answering them. There was no aha moments where we went, wow, you know, Fayette's going to take 20 red, you know, trauma level 1. So the data looks pretty accurate. So Phil, if you want to just hover or click on the question mark up there to get us started. Yep. So just want everybody aware, if you click on there and click documentation, there's a whole library here from Juvari. So all of the most updated current versions of your preferences, if you click on preferences, Phil, there's a guide there that basically is the slides that we're showing. We try to use our more regional tools that we've got. So all of that is in here for you to reference under the question mark. And then Phil, if you want to go back to our region where we're a little bit more specific to what we do here in the Hope Coalition, and a lot of it comes from the state of Illinois too. On the drop-down menu box up top, when you click menu, we've got a document library. Here it would be regional info. Phil, yours is a little different. I'm still adjusting from my Missouri side. I've got both. Yep. And EM resource. So there you go. If you go up top main menu, it leads you to the document library, EM resource, and then maybe click on that 526 webinar, Phil. There's 2 webinars up there. Again, this is more specific to Illinois and what is actually on our status boards if you open that document. Yep, come back down, Phil. Come back down to open. Yep. So that's kind of a presentation for the state. And then the other one is more specific to our region from Dan Lee on the 4.9, Phil. Just go up one from there. Yep. So again, there's the resources are here to kind of walk you through this if you're new to EM Resource. If you need to do any additional training with your staff, please reach out to myself or Lee. We will definitely make a road trip. We can get on a Teams call and walk any new team members you have to EM Resource. We can walk them through this. So I'll pause there and open up for any questions, or if anybody has experiencing any struggles they want to share. I find it will be beneficial for the rest of us. I know at BJC in the past, a lot of it again has been turnover and people leaving, and no one realized what the EM manager was doing at that location as far as entering the appropriate people and making sure the right phone numbers and pagers are in here. So I will pause there.
questions, aha moments, anything to share from the?
Yeah, this is Aaron from Alton, Sean and Lee. I could definitely use some help. I think my EM resource usage is pretty good. Uh, but I need a stronger understanding of it. And then I also need some help getting additional people at Alton trained up on D4H.
Mm-hmm. Well,
You bet.
we definitely can help with both of those things. As you bring up D4H, one of the things that we did notice from the last redundant communication drill, that was one of the tasks. The task was to, I think we started it in EM resource and had folks go into D4H, basically to test their account, put something in the log, basically, that you were there, like, Georgia was here or Aaron was here. We're trying to find a way to make this make it feel less cumbersome. Like I haven't done that in 6 months or a year. And not sure what the proper answer is, but we want to make sure folks are using, because EM resource we do use a little more often. So that's why we see obviously more success there. But I can tell you when we were, and if John Nowak's still on, EM resource was a great tool for us all through COVID. It really, really helped keep us in line with things. Not only the shared repository of information, but it was where we did all of our resource requests. We did all of those things through it. And, we've kind of lost a little bit of that muscle memory. We want to make sure that we maintain that, because when and if we do have a larger incident, and we'll use Phil's spidey senses not working, and this Baxter issue and the longshoreman strike become a really big issue over time, we're going to need to go back to it. And we want folks to, when the balloon goes up, or when things get tough, we want to be able to communicate effectively to everyone. And D4H is the tool that we're going to use to do that. And we don't want it to be like, oh, I need to get a new account and starting from scratch every time we do this. So we're open to ideas on how we can make it more a part of the fabric of day to day. So
yeah, that was I've had this on my list since last July when we did the merge back then, and I was the only one in Alton that we know of that had a D4H account, and I was in Montana. So
very nice.
Hey, Aaron, I could tell you prior to your arrival at Alton, I was out there on 2 different occasions, again, talking about the turnover with new house supervisors. And we actually went to the computer room for about an hour and a half, and we did, not only did we go through how to set up your preferences and enter, the new people into the system, but, going through what is a staffed bed versus a licensed bed, and what data are you actually entering? Kind of going through the state of Illinois and our coalition, what we're actually asking. Sometimes it gets confusing to the new users. So we can certainly go through all of that and set up any block of time you want. And, we can do a night shift, day shift, whatever. And that goes for everybody. Those 5 or 6 that are struggling, please just hang in there, and I'll reach out personally and see what we can do to support.
Appreciate it.
Indeed. As you can kind of see here, just as I know we're about to close up, but here, just as a reminder, I see Gateway. They have an issue. I saw that they have a comment here where their cath lab is closed and will advise when it's back in service. So that was updated 9/35. I didn't have any notification on that. So I have all of my notification and preferences set to whenever any one of these ED status changes. This one should have changed to a resource open, but resource limitation, identifying that the cath lab is out of service, basically. So I will be, or either myself or Lee or Mike, somebody will contact Gateway to make sure they update that. But normally, if it's St. E's or it's Shiloh or it's Anderson, if they have a change in this status, I immediately get a text and an email telling me, and that this is the situation. And that's what it's supposed to do. That's how we keep ourselves informed. That's how we maintain good partnerships and help make everyone aware of the problems that we have without making it a big deal every time, to where it stacks up and people go like, oh, wow, I didn't get notified that your cath lab was closed or the CT was down. I wouldn't have brought this patient here. I would have went to the closest, most appropriate facility instead. But now we got to stabilize and get them moved. So, this is why we have these tools, and we want to make sure we're using to the best of our abilities. So enough there. Anyone else with anything for the group with the good of the order before we break? Okay, hearing nothing, I want to thank everybody for their time. Sorry we had to keep you on a little bit longer, but we had a lot of important things to get done. Last bit of the grant is it's on its way, and we will see you guys next month. Take care, everybody. Ciao.